Thank you, everybody. I'd like to thank the CCF for inviting me to speak. I'm going to give a general overview of chimeric antigen receptor therapy in pediatric acute lymphoblastic leukemia. And so hopefully I will be able to answer a couple of the questions that were already raised to Dr. Ballard in her session with regards to pediatrics. I have no disclosures. So the objectives of the talk are to provide a very brief general overview of pediatric ALL and current treatment approaches, to review the advances in immunotherapeutic approaches for the treatment of ALL, and to discuss future directions and challenges in our field. So very briefly, childhood acute lymphoblastic leukemia, or ALL, is the most common cancer diagnosis in children. There is approximately 3,000 new cases every year here in the United States. And it afflicts mostly patients that are less than 14 years old. It accounts for about 25% of all new cancer diagnoses. As you can see here in this graph, survival has improved tremendously in each study era. So in the 1960s, sorry, this is a little bit strange. In the 1960s, here when we used single agent chemotherapy, survival curves were absolutely dismal, and as you can see, with subsequent advances in the field, such as multimodal chemotherapy, utilizing intrathecal therapy for CNS prophylaxis, our survival curve has improved to where 85 to 90% of patients will be cured. The focus of this talk will be on those relapsed or refractory patient population. So in pediatric ALL at diagnosis, we generally will risk stratify patients into two risk categories, standard risk and high risk. Standard risk leukemia patients are defined as having a white blood cell count of less than 50,000 and being between the ages of 1 and 10 years old. And high risk patients have white blood cell counts greater than 50,000 or are greater than age 10 and less than age 1. Additionally, extra things that we look at to assess which risk stratification patients should go on is whether or not they have CNS disease and if they've had prior steroid exposure. Based on this diagnosis, when the patients first present, we'll determine what leukemia therapy they would be receiving. So therefore, if they're standard risk, they would get a general 3-drug induction regimen versus high risk where they add an additional agent, so it would be a 4-drug induction regimen. Somewhere along the way in that first month of therapy, we get results back of cytogenetics and molecular features that could further identify which patients are either at low risk, at standard risk, or which patients become high risk. And then, of course, at the day 28 mark, we do testing for MRD, which we have noted is very important to see how patients respond to therapy and what the likelihood of a remission would be. So the approach to the relapsed and refractory patient has been generally particularly difficult, especially in the infant and adolescent and young adult population. And with the Children's Oncology Group and Dr. Brown as running the study, we've sort of streamlined the process where patients in their first relapse, we have one study that we are trying to filter patients in to receive the immunotherapy blinatumomab in combination with additional standard backbone leukemia therapy in order to try and define what could be best utilized in this relapsed refractory setting. So utilizing the immunotherapy and immunomodulatory system has been very helpful in that previously, before these drugs were developed, the only real way we could treat these patients is by intensifying the chemotherapy, cytotoxic chemotherapy, and this led to many toxicities that patients had with multiple rounds of steroids, multiple anthracyclines that affect cardiac function, and neurotoxicity and neurocognitive effects that have afflicted this population. And so at that point, novel therapies were being researched in the laboratories. And so this slide here is one of my favorite slides, just showing the cytotoxic therapies had been developed in the pre-2000 era, and really nothing was developed for quite some time, especially in the pediatric setting. Clofarabine came on the scene and was FDA approved in 2004. The studies that showed that clofarabine was effective as single agent studies demonstrated about a 20% complete remission rate in the pediatric setting. So it did gain FDA approval in 2004, and then shortly following that was nelarabine, another purine nucleoside antimetabolite that was utilized in T-cell ALL. Both of these drugs definitely had side effects. The nelarabine had neurotoxic side effects, and clofarabine was very myelosuppressive, and many of the AEs were due to fever, neutropenia, and myelosuppression. And then there's a very large window of time where there was no drugs in the development or approval for pediatrics. Liposomal vincristine, or Marquibo, got its indication in an FDA approval in 2012. However, this was only in the adult setting. So it's essentially taking vincristine and putting it in a soap bubble so that it lasts longer, and we're able to give higher doses. And the phase 1 studies for vincristine in the liposomal form of Marquibo in pediatrics were run at the NIH, and there's a current phase 2 trial that Dr. Nirali Shah is an investigator for, and she is that is currently open through the TACO consortium, trying to get the indication for pediatric approval through the FDA. And then blinatumomab comes on the scene and has accelerated approval in 2014, and then gets regular approval by the FDA in 2017. And this is one of the first immunomodulatory medications that has an FDA indication for pediatric leukemia. And then inotuzumab comes on the scene as a CD22 antibody in 2017, and did receive FDA approval for that. However, that is only in the adult setting. Phase 2 trials are currently underway through the Children's Oncology Group to also get that indication for pediatric ALL. So work is being done. It is a very exciting time to be a young investigator in leukemia and to take part in these trials. So Dr. Ballard did a lot of my work here when she described what CAR T therapy is. So I will be brief, but I will just go ahead and say that CAR stands for chimeric antigen receptor. So essentially we are taking the best part of a B cell, that antibody binding domain, and combining it with the functionality of a T cell, which has recognition properties, so the B cell property with the cytotoxic effect of the T cell, and we combine that together to make this chimeric antigen receptor. And so what we do here in our studies is we identify patients that could potentially be trial candidates. They undergo apheresis, so we do a lymphocyte collection. We stimulate their lymphocytes in culture. We add and we transduce them with a lentiviral vector. For one of our trials, we did a retroviral vector for a CD19 CAR trial. And then we do cell expansion in the laboratory, and it takes about 10 days for our cells to grow. During this time, our patient is admitted, and we are giving lymphodepleting chemotherapy at the NIH. We use flu-cy regimen, and then CAR T cells get infused on day 0. So major questions in the field at this point are how to select the best CAR. So antigen selection is a very hot topic at this point because, as you've heard, all of the buzz is about CD19 with really good reason. However, antigen loss is a significant problem that we're encountering in the community, and so we need to continue to make these multiple antigens available for our patients, but we have to limit off-tumor toxicity. And so one of the main toxicities in treating B-cell ALL by targeting B-cell antigens is B-cell aplasia. And that's great because we have immunoglobulins that we can replete on a monthly basis to try and help protect patients from viruses and et cetera. However, if you're targeting, let's say, CD33 for AML and an AML CAR, you can't live without your myeloid compartment. And if you have a long-acting CAR, that's going to cause a lot of problems. And so trying to figure out what we can do in order to continue to advance the field, continue to make new antigens, that's obviously what people are working on in the lab. And then, of course, managing side effects. General cytotoxic chemotherapy comes at a price. As I discussed, patients have endocrinopathies after therapy. They have bone disease growth problems. They have cardiac dysfunction. And truly, in our CAR therapy, although those side effects may occur, we are seeing different side effects, such as cytokine release syndrome and neurotoxicities, for which we don't have excellent explanations for at this time. So major toxicities from chimeric antigen receptor therapy is cytokine release syndrome, neurotoxicities, and on-target off-tumor toxicity, again, such as B-cell aplasia. So this is a slide from Dr. Kokendorfer's group, and it just has a really nice picture that explains all of the possible things that could occur during cytokine release syndrome. And really, CRS is inflammatory response to the chimeric antigen receptors being infused and actually growing in the body. And it could really present in a number of ways, but typically the first symptom that we see is fevers. And so constitutionally, it looks really like you're having a pretty bad flu. You have fever, myalgias, fatigue, anorexia, but it could escalate relatively quickly, and it can get to a point where you have cardiac dysfunction, hypotension, you can have elevated LFT markers, anemia, thrombocytopenia, and actually a complete sort of shift in the spectrum to hemophagocytic lymphocytic histiocytosis, where you have an overzealous immune system where you're activating it, and you have sort of the immune system attacking itself. And we have seen that in some patients. Done at the NCI with Dr. Daniel Lee, Crystal Makel, Dr. Fry, and Dr. Nirali Shaw. And this was a 19 targeted CAR using the 28 zeta. So the 28 zeta is that co-stimulatory domain that Dr. Ballard talked about. These CAR T cells are generally thought to have a quicker on switch, so they grow more rapidly initially, and then they sort of taper off, and they generally don't last more than a few months at the maximum. And that's generally speaking. There are some patients on each side. But the toxicity is definitely seen a little bit earlier than with the 4-1BB. That is generally thought to be a little bit more of a slower growing CAR that has longer persistence. So our CAR was a CD19 28 zeta CAR. And this is a waterfall plot that is demonstrating that in this first cohort of patients that was reported in the literature, patients definitely had responses and complete remission rates as seen here in the blue. This was an intent to treat analysis, so this was all comers, even patients that did not get infused. And so the complete remission rate seen at the NCI in the POB was 67%. Important to note that all patients that had responses did have cytokine release syndrome, so that was something that we noted pretty early on. Shannon Maud et al. From CHOP had a CD19 41BB CAR construct that was in her clinic, and they saw a 90% complete remission rate, and this was patients only infused with CAR T cells. And she also noted the importance that CRS was also seen in all patients that had a response. And then you heard about the group from Seattle. Rebecca Gardner et al. Is the pediatric person that is running the pediatric trials, and this was her intent to treat analysis of CD19 CAR T cells. She is from the group that does the CD4, CD8 in a 1-to-1 ratio, and they saw the 89% CR rate in this intent to treat analysis. This prompted a more global CD19 registration trial that Novartis had sponsored utilizing the CHOP construct, and 61 of 75 patients on this study achieved a complete remission, and the intent to treat was on par with our study, with 66% of patients achieving a CR. This led to the FDA approval of Kymriah, which is what we heard about with Dr. Ballard, and this was the first pediatric cell therapy product that was approved by the FDA. So the indication initially was approved first in pediatrics prior to this adult approval, which just happened May of 2018 for diffuse large B-cell. Kymriah got its FDA approval. Tocilizumab was also approved at the same time in August 2017 as with the Kymriah for the pediatric B-ALL population, and tocilizumab is used as an IL-6 receptor blockade to help ameliorate some of the side effects of CRS. And Yescarta was recently approved. This is the kite CAR that was used at the NCI. It's the NCI construct, the CD19 28 zeta, so the shorter acting CAR was recently approved in October 2017, and its first indication is for diffuse large B-cell lymphoma in adults. And for phase 1 studies, this complete remission rate is very remarkable at 50 to 80%. If you remember in the slide that I showed you with the clofarabine and the nelarabine, we're talking on order of phase 1 studies, single agent, complete remission rates in the 20%. So this is absolutely remarkable for early phase studies. As was discussed, antigen loss is present in up to 40% of cases post-CD19 CAR therapy, and there are various mechanisms being investigated at this time. However, two mechanisms that I would discuss is mutations in exon 2, which results in the loss of the surface epitope, and so the CARs can't see the leukemia. There's nothing for them to actually target. Additionally, some isoform switch was being investigated in frameshift mutations where the full length of the CD19 antigen was no longer present. And then Seattle and our group at the NCI demonstrated that lineage switch was occurring in some patients. Dr. Gardner demonstrated that in MLL rearranged patients with ALL, after being treated with CD19 CAR therapy, those patients that relapsed had myeloid phenotype at the time of relapse. And Dr. Jacoby and Terry Fry's lab demonstrated that CAR immune pressure was enough to create a myeloid phenotype switch. So with the CD19 CAR being taken underway, the NCI opened up the CD22 CAR clinical trial to treat patients with relapsed refractory disease. NCI has a long-standing history with the CD22 antigen between the moxetumomab trial that Dr. Shaw helped run and the CD22 site density that Mary Alice and Connie were working with in the pathology lab. We noted that CD22 is pretty ubiquitous on most ALL populations, and so it was a promising target. We developed a second-generation CAR utilizing M971 construct, and we attacked this with a 4-1BB. We utilized lymphodepletion as we did with our CD19 with Flu/Cy, and our first patient enrolled in the study in 2014. So as you can see here, this is an immunohistochemistry plot of CD79A, and this is a patient's bone marrow biopsy that is very afflicted with disease. This is pre-treatment, all of the pink that you see here, and this is her post bone marrow biopsy where you see a lot of fat cells, but this light blue, those are regular cells that are not staining for CD79A, and this is a pan B cell marker that we use in the lab to look at leukemia. This is the same patient's flow cytometry plots. So this is her leukemia here. As you can see, this is her peripheral blood. This is day 1, about 10% disease here. And you just follow this red population. At day 7, she has even less disease. And then by day 2, nothing is detected, and that persists at day 20. And down here in this panel of flow cytometry, this is our CD22 CAR. You do not obviously detect it on day 1. You start to see a good population at day 7. And then at day at day 12, you see 77% of T cells expressing our CD22 CAR. And we have complete remission rates on this trial. We have actively accruing, and we have accrued at over 40 patients, and we have a complete remission rate of 70%. We've seen limited cytokine release syndrome, grades 1 and grade 2, and we've seen limited neurotoxicity as well. We've also seen that relapses are associated with modulation of CD22, and we have had a couple cases in which CD22 antigen was lost. This is the characteristics, our first 22 patients on our CD22 CAR trial at dose level 2. The median age was 17. We had a slight male preponderance, and a lot of patients were heavily pretreated. 18 of 22 received bone marrow transplants. As you can see, 20 patients had received prior CD19 therapy, and we even had 2 patients that received a prior CD22 CAR at a different institution. Over half of our patients were CD19 negative or dim. A majority of our patients had an M2 marrow or greater, meaning that they had a bone marrow that had more than 5% disease. And extramedullary disease was noted in 6 patients. This is our dose escalation for our CD22 study, and as you can see, with the 3 × 10⁵, this is non-T cell selected. We treated 6 patients. We had 1 dose-limiting toxicity, but we had pretty low efficacy. We then increased our dose to dose level 2 at 1 million cells. We treated 3 patients. 3 of 3 patients had a response. At dose level 3, we treated 2 patients. We had 1 grade 4 hypoxia. So one of 2 patients had a response to that. So that we had dose level 1 low efficacy. At dose level 3, we had high toxicity. So we decided to go back down to dose level 2 and do our expansion cohort at 1 million CAR T cells per kilo, which is currently what the CD19 CAR trials are utilizing. This is a waterfall plot that was recently published in Nature Medicine by Dr. Terry Fry and Nareli Shaw. And this just shows, again, the complete remission rates that we had seen on our CD22 CAR trial and whether patients had CRS or not. And so our intent to treat analysis, it was a 60% complete remission rate. Our longest remission is about 2 years post-CAR therapy. For our patients on this study, the general persistence of the remission is about 6 months, at which point we're starting to see the loss of CAR T cells. And in patients who are trying to give CAR T cells a second time around, we're noting that the CAR T cells are not expanding as well as we want them to. So we have, in this study, done increased lymphodepletion, which has led to an MRD negative complete remission in one of our patients. So modulation of CD22 expression, this just shows that 10 patients with relapse, 1 patient had CAR loss, which was at dose level 1, and another 7 had changes in CD22 expression, as you can see here on this graph. So CD22 site density was measured prior to infusion and then at the time of relapse. And we had 7 patients that had changes in CD22 site density. And a few who had antigen loss. Patients that typically had antigen loss received either CD22 CAR prior to us receiving our CD22 CAR, or they received inotuzumab, that CD22 antibody. In our CD22 study, based on the CD19 data that was available to us, we joined teams with our psychology department and incorporated a systematic way to evaluate our patients prospectively, utilizing neurocognitive assessments, in addition to developing a caregiver report where they would be able to fill it out during therapy to talk to us about some subtle toxicities that the care team might miss. What we were able to demonstrate, at least in the CD22 CAR arena, was that most patients showed stable to improved cognitive functioning across all domains tested. Our neurosymptom checklist was able to detect subtle changes in status captured that was not easily captured by current CTCAE criteria. And additionally, and very importantly, utilizing our neurosymptom checklist, caregivers were able to report more subtle symptoms that were often not detected by the medical team. So our summary from our initial experience with CD22 is that this was the first successful salvage CAR therapy for CD19 negative B-ALL patients. Our preliminary data suggests that it has comparable potency to the CD19 CAR. We also have seen that response is correlated with dose level. We've seen mostly grade 1 and grade 2 cytokine release syndrome. On this study, we had no severe or irreversible neurotoxicity. And we also saw that relapses were associated with changes in CD22 site density. Our current and our brand new CAR trial that we are running at the NCI with Dr. Shaw as the PI is a combinatorial approach utilizing the CD19 and CD22 CARs in one CAR construct. And this is the work of Haneen, who was in the Fry lab, and she developed a model in which the CD19 and 22 SCFE CAR vector was in one T cell. And so this study was just recently opened, and we've just treated our first patient in May 2018. Our hypothesis utilizing this multi-targeted approach is that by simultaneously targeting CD19 and CD22, we could diminish the risk of antigen loss, and that takes some of that CAR immune pressure off of one antigen and kind of divide it up between the 2 antigens, with hoping that we can decrease the rate of relapse post-CAR therapy. With this clinical trial, I was awarded the Next Generation grant by CCF, and with the money utilized from CCF, we will go towards biological correlates for this study. And so I look forward to updating you on the future with once we start to enroll more patients. Future directions for CAR. This is certainly an active field, but there's a lot of questions that remain. So novel CAR constructs are certainly down the pipeline. We have a CD33 CAR that we're working on at this moment, trying to open at the NCI in a different institution. Optimizing second infusions for CAR patients. We have seen by trying to re-infuse CAR patients that it doesn't go generally very well. There's some immune effect that occurs once the cells are infused, where some patients will have a little bit of a cytokine release or a little bit of an expansion potentially, and then the CARs do not expand to the degree that they need to in order to treat the leukemia. Improving CAR persistence is something that we're trying to work on as well. Improving tumor sensitivity by enhancing antigen expression. We have a hopeful clinical trial that will be opening up utilizing Briostain, which will help boost the CD22 site density on cells and giving that either prior to CAR or post-CAR in patients that have relapsed. And of course, we discussed when CAR is appropriate in the leukemia treatment paradigm. There are many talks of trying to move CAR into upfront therapy, so patients that aren't as heavily pretreated, their T cells are not as beat up. And so if we were able to bring them into the treatment plan earlier, would we be able to produce products that actually have longer lasting implications? Exploring response in lymphoma and CNS disease. So the lymphoma trials in adults are pretty impressive. However, we haven't had many lymphoma patients in the pediatric setting, and so that is something that we're actively working on. We have a lymphoma cohort on our CD22 CAR trial that we are recruiting, and additionally CNS disease. CNS disease, typically with the neurotoxicity and not really fully understanding the mechanism, people have been reluctant to treat patients with CNS disease because of that, but we do know that CAR cells traffic to the CNS. We can find them based on flow cytometry in our patients when we do assessments at the 1 month time point, and that patients do respond. On our CD22 CAR trial now, we have a CNS cohort only. We've treated one patient, and that patient is out 9 months, and at the 6-month evaluations at least is in a complete remission. Of course, decreasing toxicity as we have multiple CAR products that are trials that are currently in research. We need to continue to utilize what's safe and what's effective. And so the cytokine release, being able to come up with the grading criteria that Dr. Ballard showed, when you should treat side effects, so sometimes earlier is a little bit better. So utilizing tocilizumab prior to patients becoming hypotensive and needing multiple inotropes in the ICU. We're learning more and more about what effects these medications will have on the CAR T-cell product. And then obviously improving access. Dr. Ballard was nice and did not discuss cost for the Kymriah product. It's about $500,000 for insurances that hospitals are asking for sort of in the upfront setting to pay for one person to receive that therapy. And so it's extremely expensive to receive these products. And this is all very new. The approval was just a few months ago. So trying to figure out the landscape of that is in improving access to patients that potentially their insurances don't approve would be extremely important for us to know. There's a lot of people to thank. I'd like to thank the POB and the CCR for allowing me to help run these trials. Dr. Nurali Shah is my mentor. She has helped train me and grow me up in this program where, it wasn't a field that I thought I would see myself. And over the last 2 years, it's just been an incredible ride, and it is fascinating, and I've learned very much from her, so I would like to thank her. Dr. Terry Fry for taking me into his lab and taking a person who didn't know a thing about basic biology research and teaching me how to hold mice and inject T cells into tail veins. So Terry, I'd like to thank you as well. Obviously, Brigitte and John, thank you very much. Our team at the NCI, our Department of Transfusion Medicine, our cell processing team, our nurses, and of course our fellows, who a lot of them are here, who help take care of our very sick patients. We appreciate all the work that you do. Our patients, families, and referring teams, we couldn't do this work without them. And of course the funding support that I have received currently as the 2017 Next Gen Award by CCF. I'd like to thank you for having me speak. I'll take questions.